Okay, I think we can probably get started now. Hi, everyone. I'm Ali Rouhani. I'm professor of epidemiology at the University of Washington. Welcome to the Epidemiology COVID-19 and Sequelae Flash Science session. Thanks for joining us. We are thrilled that you're here. As a reminder, the session is being recorded and chat is disabled, so please use Q&A feature for all the questions that you have. If you have a question for our presenters, please ask it by typing in the Q&A feature in your bottom menu bar at any time. Q&A will take place after all the abstracts have been presented, but we encourage you to send in questions throughout the session. We'll answer as many questions as we can as time allows. This session has 10 presenters, so it will go really, really fast. A live transcript is available for the session. If you prefer to hide the captions, please click the up arrow next to the transcript button and select hide transcript. So with that, join me in welcoming our 10 presenters, abstract presenters today. I'll go in order. Sarah Bird-Sharps, Director of Research at Everytown for Gun Safety. Dr. Kristen Crichton, pediatrician at Nationwide Children's Hospital. Dr. Marianne Mason, Associate Professor of Emergency Medicine at Northwestern University. Dr. Rebecca Sokol, Assistant Professor of Social Work at Wayne State University. Dr. Vivian Lyons, Postdoctoral Fellow with the FACTS Consortium at the University of Michigan. Dr. Katie Donnelly, Assistant Professor of Pediatrics at the George Washington University School of Medicine. Dr. Bindi Naik Mathuria, Associate Professor of Surgery and Pediatrics at the Baylor College of Medicine. Dr. Stephanie Bonney, Associate Professor of Surgery at Rutgers, New Jersey Medical School. Dr. Peter Ehrlich, Professor of Pediatric Surgery at the University of Michigan, and Jennifer Paruk, PhD candidate at Michigan State University School of Criminal Justice. So we will begin screen sharing the presentation at this moment, and Sarah Bird-Sharps is our first presenter.
Hey everyone, thanks so much for joining this session. And I have 3 minutes to tell you a bit about a report that we came out with a couple of weeks ago, if you want to go to the next slide. So for more than 6 years, we've been methodically tracking every incident where a child under 18 gets their hand on a gun and unintentionally shoots themselves or someone else. We use media tracking and we verify it always with at least one other source, whether it's Gun Violence Archive or some other organizations that are collecting this. And while gun deaths among the vast majority of kids are homicides and suicides, these unintentional shootings by children result in one of these tragedies almost daily. And so our new report, where there's a link there, has analysis using this unique database as well as other research. And our research question was, what can the profile and circumstances of these incidents and the impact of laws intended to prevent them tell us about avoiding these tragedies? Next slide, please. So in the 6 years from 2015 through 2020 that we've been doing this tracking, there have been over 2,000 unintentional shootings by children, resulting in 765 deaths and over 1,300 injuries. And while the range of victims of these shootings span from like a 1-month-old child to a 77-year-old man, most of them are also shootings of children. So 91% of those injured or killed were also under 18. These unintentional shootings occurred most frequently when children were likely to be home over the weekend, in the summer, during school holidays. And for instance, in 2020, there were 3 unintentional shootings by children on Christmas Day alone. The 2 age groups most likely to be both shooters and victims were, first, unsurprisingly, teenagers 14 to 17, but second, preschoolers 5 and younger. The vast majority of these incidents resulted in a single injury or death, underscoring the fact that these children never meant to inflict casualties. And roughly half of the incidents were situations where a child shot him or herself. And then the 2 pie charts on the right are 2 additional pieces of analysis from this research. One is about what kind of gun was used. And while it's very hard to find out the kind of gun from the kind of tracking we're doing, in 65% of the over 2,000 incidents, we were able to get the type of gun, and it was largely handguns, so 85% handguns. The second really important piece of information from this to help us understand what to do about it is that these incidents occurred by and large in homes. So 70% of the incidents occurred either in the child's home, in the home of a relative, in the home of a friend, somebody they were over for a play date, or some other home. So nearly 3 in 4. Next slide, please. So the next thing we wanted to look at is what's happening state by state and what about policies in states, and doesn't matter. I'm going to start on the right here. So we looked at every state, both number and rate of children of victims, not just children, who are killed or wounded, and we found enormous variation. So in Louisiana, there were 98 incidents over the 6-year period they were tracking. In Hawaii, New Hampshire, and Rhode Island, none at all. In the 10 states with the highest rates of injury and death, rates were on average over 12 times higher than in the 10 states with the lowest rates. And then when we looked a little deeper, you can see the 2 tables on the left. I'm sorry if those too small, but anyway, we looked at the states. The top table is the 10 states with the lowest rates of injury and death, and we found that all of them, except Wyoming, had some form of child access law. And for the 10 states with the highest rates of injury or death, 4 of them had no law at all, and 6 of them had a law only in extremely limited circumstances. And so just to finish up by saying what became really clear from this work is that secure gun storage is really the indispensable ingredient to avert these incidents. And we talk about gun storage practices, gun storage public education campaigns, and gun storage laws. Thank you very much.
Great, thank you, Sarah. So next is Dr. Crichton.
I'm Kristen Crichton from Nationwide Children's Hospital, and I am presenting pediatric firearm injuries during the COVID-19 pandemic. Next slide. So we noted at our institution a really significant increase in frequency of pediatric firearm injuries during the COVID-19 pandemic, and we set forth in this report to describe epidemiologically the patients that were seen during that time period. So we did a retrospective chart review of patients seen at our Pediatric Trauma Surgery Center, which is a large Midwest Level 1 trauma center at a freestanding children's hospital, for a firearm injury between February 1st, 2019, February 29th, 2020, that was our pre-pandemic time, and then March 1st, 2020 to March 31st, 2021 was our pandemic time period. We excluded patients with firearm injuries that were not assessed by our trauma surgery team. We also excluded patients with injuries from non-powder guns. Next slide. So in that pre-pandemic time period, we had 28 patients with firearm injuries as compared to 80. So a nearly 3-fold increase between pre-COVID and during COVID. But you can see in that table there that there was really no significant difference between the pre-pandemic or pandemic groups for sex, race, or age, interestingly. However, when we compared the racial composition of these groups with the catchment area, as well as all comers or injuries, all injuries that we see at our hospital, we really noted that there was an overrepresentation of Black children in both the pre-pandemic and pandemic groups. We were also able to categorize injuries as a result of accident or unintentional injury versus violent or assaultive acts. The proportion of those was the same in the pre-pandemic and pandemic time periods. And then the other aspect we looked at with these groups, because we have such a large diverse catchment area, was we used zip code data to look at changes in the breakdown between rural and urban areas. And again, we saw no difference. Next slide. So despite this nearly 3-fold increase in pediatric firearm injuries seen at our institution, the demographics was really the same between the pre-pandemic and pandemic time period. And we continue to see Black children really be overrepresented as compared to our catchment area and all injuries seen here. And we really think this reflects a need for ongoing and targeted preventive measures to really keep those kids that we know are most at risk safe. Thank you.
Thank you, Dr. Crichton. Next is Dr. Mason.
Hello, good afternoon, everyone. I'd like to acknowledge the team I worked with from our university for this project, including Joe Fineglass, Karen Sheehan, Audrey Brewer, and Rushman Kazini. So we are looking at 2 peak years in firearm homicides in Chicago, 2016 and 2020, with the notation that it looks like 2021 will also be a peak year. Next slide, please. And what we want to do is compare the age distribution of firearm homicide decedents across these 2 peak years, 2016 and 2020. So our data source was publicly available data from the medical examiner's case archive in Cook County, where Chicago is located. We included all cases that occurred in Chicago with the manner ruled homicide and gun-related endorsed. We recoded into age groups, 5-year age groups, and we compared the number and percent of homicides by age group annually across 2015 through 2020. And we use that time period just because the data became publicly available in 2015. So that's where we start. We use chi-squares to look for significance. Next screen, please, or slide. We had over 3,000 firearm homicides during this 6-year period. And we do note an increase in the mean age in firearm homicide decedents of over a year. And if we look at the distribution of firearm homicides by age group, we see that that has changed between 2016 and 2020. And what we're seeing is a decrease in the 15 to 24-year-old age groups, which were peak groups in the past, and an increase in the under 15 and then the 25 through 44 age groups. Next slide, please. So this, of course, raises probably more questions than it answers, but just in terms of thinking about further research, outreach, and intervention, leaves us with a lot of questions. Importantly, how do we reach the adults, the older adults in this group who are at risk of increased violence? And do we need to add approaches, or can we just expand what we're doing already, which is mostly focused on youth? Do we need to rethink program age limits in terms of cutoffs? And we want to know, are there increased opportunities based on returning citizens for people who may be leaving corrections for adults? And then I think most importantly, thinking about the children involved here, we really need to know, are the under 15 group, are they involved in violence, or are they unintended victims? Are they children of adults who have a violence involvement? And secondly, is there a generational impact going on here? Is the current peak age a result of a continued violence among those who were most at risk in 2016, or is it a new direction? So thank you.
Thank you, Dr. Mason. Next is Dr. Sokol.
Hello, and thank you for listening in on this presentation. In this short talk, I'm going to be talking about some results from the FACTS National Survey on looking at the association between different types of violence witnessing and different risks for later violence perpetration among teens. Next slide, please. So we know that being a victim of firearm violence approximately doubles the probability that an adolescent will subsequently perpetrate serious violence. But the association between witnessing firearm-related violence and teens' risk for future violence perpetration has yet to be identified. And so in this study, we use nationally representative data from the FACTS National Survey of Parents and Teens to evaluate the association between different types of teen violence exposure, namely witnessing non-firearm violence, witnessing firearm-related violence, and violence victimization on risk of violence perpetration, as measured by aggression, retaliatory attitudes, and firearm carriage. And we assess these using both multivariable logistic and linear regression, and use data from the FACTS National Survey. Next slide, please. The figure on the left presents results from the multivariable linear regressions predicting teen aggression and retaliatory attitudes. And the figure on the right presents results from the multivariable logistic regression predicting firearm carriage. And we standardized all continuous dependent variables to allow for comparisons between the different models. So what we see in the left figure is that violence victimization was associated with aggression, but no other violence exposures were associated with aggression. Now, all three types of violence exposures, both witnessing non-firearm related violence, witnessing firearm related violence, and violence victimization were all associated with retaliatory attitudes. Now, what we see on the figure on the right is that only witnessing firearm related violence was associated with firearm carriage. Next slide, please. Overall, this study clarifies that different types of violence exposures are associated with different types of risk for future violence perpetration among teens. And so individual level interventions that are focused on reducing future violence involvement would really benefit from identifying teens' prior violence exposures. And the strong association between witnessing firearm violence and firearm carriage suggests that there's really something unique about witnessing firearm violence as compared to other violence exposures with respect to future firearm carriage.
Thank you, Dr. Sokol. Next is Dr. Lyons.
All right. Thank you. So I'm excited to talk with everyone today about variations in firearm access among teens with a history of violence perpetration. And a big thank you to my team, most of whom are also FACS folks from different institutions. Next slide. So the big question that drove this study was whether or not firearm access among teens was associated with violence perpetration in youth. And we, like Dr. Sokol, used the FACS National Survey, focusing specifically on the teen responses. We included any teens who consented to the survey, so it was a little over 2,000 teens aged 14 to 18. We used survey weighting and logistic regression adjusting for sex. Our exposure was firearm access, which we defined as a binary measure of when teens endorsed any of the following on this list. So teen ownership, ability to load a firearm on their property, household unsecured firearms, or parental permission to use firearms, or reported accessing a firearm they were not supposed to. We additionally looked at perceived firearm access as well, although this was not included in our definition of firearm access, and that was a measure of whether or not teens reported that it would be very easy or extremely easy to access a firearm that was not on their property. For violence, we consolidated both peer and intimate partner violence perpetrated in the prior 12 months and kept measures of moderate and severe violence separate. So for moderate violence, it was sort of like twisting an arm, pushing or shoving another individual. And then severe is more severe physical violence, so beating up, choking, threatening someone with a gun or knife. We also looked at any violence perpetration measures where we collapsed moderate and severe violence. Next slide. So we found overall almost half of teens reported some form of firearm access, 45%. Violence perpetration was much less common. So 7.8% overall reported some form of violence perpetration, most of which was moderate. When we look at the odds of violence perpetration by firearm access up in the upper right-hand corner, you can see that it is associated, firearm access is associated with increased risk of violence perpetration, and it remains, the association remains significant for moderate, severe, and any violence, although it is, although it looks like it's slightly increasing for more severe forms of violence. For the reported firearm access method, the parental permission for household firearm use was the most common. And it was about 45% for endorsed amongst those with violence perpetration, and about 33% reported for those without any violence perpetration reported. When we looked at those who had perceived firearm access, we saw that buying from a friend and taking a firearm without permission were the two most common among those with a perceived firearm access. And next slide. So even in this low risk cohort, there were 45% of teens who reported real firearm access. The household firearm access, I think, remains the most common method for firearm access, even amongst those who report perpetrating violence. And, you know, albeit with all the limitations that come with this sort of study, I think it really highlights that safe storage and restricting youth access remains important to reduce severity of violence perpetration, as well as risk of unintentional injury or suicide. Thank you.
Thank you, Dr. Lyons. Next is Dr. Donnelly.
Hi, thank you for having me today. I'm Katie Donnelly from Children's National in Washington, D.C. I will be discussing evaluating the validity of ICD codes in identifying pediatric firearm injury, injury intentionality, and firearm type when compared to natural language processing. Next slide, please. As we've talked about, I think a lot today, ICD codes are used in hospital data research to identify disease states, but they have definitely been shown to have limits. ICD codes for other disease states can be variably accurate. And as other speakers have mentioned, intent of injury for firearm injury is variably coded, possibly as there are no agreed upon definitions of ICD code. Now, there is a wealth of data located in the narrative notes of medical records, but as I'm sure we're all aware, it's time intensive and costly to extract. One solution may be natural language processing, which can use narrative data to derive algorithms for identifying different disease states, but these have not yet been identified for pediatric firearm injury. Therefore, our research question is, can natural language processing, or NLP, be superior to ICD codes in identifying pediatric firearm injury, injury intent, and type of firearm used? Next slide, please. So we are in the process of performing a retrospective cohort study of any patient aged 0 to 17 years old seen at one of 7 PCARN emergency departments between January 1st, 2012 and December 31st, 2019 for firearm injury. Patients will first be identified via ICD-9 or 10 code. We will then perform a manual chart review to confirm firearm injury, intent, and type of firearm used. Then, using a selection of this data and a selection of known non-firearm injuries, natural language processing will derive algorithms for determination of those 3 classifications. We will then use these algorithms to evaluate the entirety of the PCARN database from 2012 to 2019. Any charts newly identified by natural language processing will undergo manual chart review again to determine firearm injury, intent, and type of firearm used. Next slide, please. So this is some of our initial data. So this is all identified by ICD code only. The first thing that jumps out of me is this is quite a large sample of pediatric firearm injuries, over 3,000 visits. Though these charts have not yet been reviewed for accuracy, and due to our desire to miss as few firearm injuries as possible, we have likely pulled in some non-firearm injuries, such as BB guns. There is an interesting skew toward accidental firearm injury in our population, as this does not agree with previous data and suggests that more assaults occur than accidents. This may be due to the non-firearm injuries, as I've mentioned before, or the variable coding of bystander injuries. Unsurprisingly, racial disparities exist in our data. Black children have a higher percentage of all injuries, despite only making up 13% of the US population. They are also a larger proportion of the assault injuries. White children are more likely to have self-inflicted injuries, though we recognize that this is a gross underrepresentation of the number of suicides by firearms, as these children unfortunately tend not to live to receive care. But of the self-inflicted injuries that present to the ED, far fewer make it to discharge than other intents. Our next steps are to continue our manual chart review and develop our NLP algorithms, and we hope to see you back at FACS next year to present our data. Thank you.
Thank you, Dr. Donnelly. Next is Dr. Naik Mathuria.
Good afternoon. Thank you for this amazing opportunity. I just want to start by saying that this work has not yet been published, so please don't share the results quite yet. Next slide, please. So there's no national database for non-fatal firearm injuries, as we talked about earlier this morning. Most publications and media report data on fatal injuries, whereas we know that non-fatal are more common. Knowledge of the full scope is important to guide injury prevention, interventions, and policy. The public health approach to intervention is defining the problem, identifying risk and protective factors, developing and testing strategies, and then assuring adoption. Our research focuses on the first 2. So we pulled fatal injury, firearm injury data from Whiskers and non-fatal firearm injury data from the National Trauma Data Bank, which is a robust database of data from over 900 trauma centers in the country. We looked over this 10-year period at all children, and then we compared the population based on US census data for corresponding years. Next slide, please. And here's some of the findings very briefly. Over the 10-year period, we found that 14,000 fatal injuries and 30,700 non-fatal injuries, so 2.5 times more, were present in children. There was a steady increase ever since 2014. These pictures here of the demographics represent the proportion based on crude rate per million population. Non-fatal injuries and fatal injuries were both most common in Black children, specifically males, followed by Hispanic for non-fatal and white for fatal. And males were significantly more commonly injured or killed by firearms than females. When you look at the shooting causes on the right, this is really interesting data. If you just looked at the NTDB data, you would think that unintentional injuries were pretty significant, 20%, and suicides were minuscule. If you look at the fatal injury data only, you would think that unintentional injuries are not important at all. They're only 6%, but suicides make up about 1/3. So it's really important to combine both of these. So when these are combined, unintentional injuries are 15%, suicide or suicide attempts 13%. So in total, about 1/3 of these injuries, and most of these suicides, as we know, in kids come from guns found at home. So in total, about 1/3 of these injuries could have been potentially preventable by safe storage. When you look at temporal trends and shooting caused by race, assault most common in Black non-Hispanics, suicide most common and rising in whites, and unintentional most common and rising in Black young children. The Midwest and the South were most affected, and the rates are rising, especially in unintentional shootings. Assault is high in all of them. The Northeast is the least affected. Next slide, please. So in summary, the total burden of pediatric firearm injuries is even more significant commonly believed when non-fatal firearm injuries are included. I don't have this data here, but these numbers are actually higher than what's been reported in the same time period by the Gun Violence Archive as well. There is a need for a national database for non-fatal firearm injuries or a national reporting system, just how we have to report reportable diseases or child abuse in the ER, maybe we should be reporting firearms. And then unintentional injuries and suicides make up almost 1/3 of pediatric firearm injuries, highlighting the need for safe storage policy and interventions, maybe more than previously thought. Vulnerable populations identified from the study are Black teenage males, Black non-Hispanic young children for unintentional shootings, and white non-Hispanic children starting at the middle school level for suicides. The Midwest and the South are most affected. Thank you.
Thank you, Dr. Mathurio. Next is Dr. Bonnie.
Hey everybody, thank you for the opportunity to talk a little bit about our work today. My name is Stephanie Bonney. I'm a trauma surgeon in Newark, New Jersey. Next slide. So the purpose of this project was really to better understand the burden of initially non-fatal injuries that sort of lead to fatal sequelae down the road. And so as a trauma surgeon, one of the things that we see a lot is these patients who are injured who either have complex abdominal injuries or brain and spinal cord injuries who go on to have a long sequelae of hospitalizations, multiple hospitalizations, and then ultimately typically have years of lives lost. And so we were interested in studying, is that a real phenomenon or is it just kind of in our heads? So there's really no firearm data set at all. We've talked a lot about non-fatal injury today, but there's really nothing that talks about what happens to the people who survive their initial gunshot wound and then die years later from the complications. So we used our single center data, our institutional trauma database, to review all gunshot wounds aged from the year 2000 to 2017. We're a high volume urban trauma center with about 4,000 trauma activations and about 600 gunshot wounds per year. We matched these patients to the Regional Health Information Exchange and looked at all their future hospitalizations. And then we also looked them up in the Social Security Death Index and the National Obituary Registry. Next slide. We identified at our center a total of 73 brain injured and 86 spinal cord injuries in the 17 years of our study from firearm injuries that ultimately went on to survive their index hospitalization. The median age at presentation was age 27. Patients were predominantly male and Black, which reflects our socioeconomic demographic in our trauma center. 20 brain injured and 32 spinal cord injured patients were lost to follow-up after their initial hospitalization. We weren't able to identify them either in any subsequent hospitalizations or in the death registry. 9 of the brain injury patients and 11 of the spinal cord injury patients subsequently died with a median age of death of 32 and 26 years respectively. The average time to death was about 1,000 days. Younger patients and those who have longer initial hospitalizations were more likely to die. And notably, in the ensuing years, the remaining 106 patients accounted for 745 hospital encounters, 545 which were in the emergency department. Brain injured patients typically came back with skin and soft tissue infections, musculoskeletal complaints, neurologic complaints, and spinal cord injury patients often came back to the emergency room and to the hospital with urosepsis and complications from decubitus ulcers. We had a total of 1,226 premature years of life lost identified in this fairly small cohort, representing a total direct loss of economic contribution of over $38 million and a willingness to pay estimate, which talks a little bit more about how people contribute to the economy, of over 122 billion patients. Next slide. So in summary, these late deaths are not really collected in any public health data, and these patients go on to have significant costs to society and to the healthcare system, and we should be accurately collecting this subset as well.
Thank you, Dr. Bani. Next is Dr. Eric.
Thank you, everybody. I'd like to thank my co-authors for the work on this project, and similar to others, this work has not been published, so please be careful in quoting it. Next slide. Oops, start my video. Oops, thank you. I didn't realize that. Okay, limited data is available on the mental health consequences following a firearm injury in children. Alternatively, when we look at motor vehicle crashes, predisposing conditions, treatment, and follow-up is very well described and has been a good model of overall improvement for reduction of both fatal and non-fatal injuries in children with motor vehicle crashes. And the purpose of this study was to determine the one-year new mental health diagnosis following a firearm injury in children. To do this, we looked at the Medicaid market scan database, and we did a retrospective propensity study that was matched looking at children 1 year prior to and 1 year after the injury date. We matched them because motor vehicle crashes far outweigh firearm injuries on 3-to-1, and we also matched them on age, gender, and date of injury. And we report our results as adjusted odds ratios for new mental health diagnosis. And these were adjusted for race, complex chronic conditions, and severity of injury. Next slide, please. So if you look over on the right of the slide, it really, this forest plot kind of highlights our results. You can see that the adjusted odds ratio for any new mental health diagnosis is about 1.5 times greater in the firearm group than in the motor vehicle crash group. And these are new mental health diagnoses before. If we look at the two below that, the two highest diagnoses following a firearm injury are substance-related addictive disorders, as well as trauma and stressor-related disorders. If you look over on the left, we did an initial exploration to try and look at severity of injury. Although ISS score is helpful, it does have limitations, and we used a surrogate of those who were admitted, those were admitted to the floor versus those admitted to the ICU, and any hospital admission was associated with a significant increase in the likelihood of a new mental health diagnosis. Finally, based on some adult data that have been published a few years earlier, that the type of firearm may relate to the type and severity of the mental health diagnosis. We attempted to look at that within our group, but as was noted by someone else presenting earlier, one of my colleagues today, the coding of this leaves a lot to be desired, and we could not make out whether any type of firearm injury was associated with any type of diagnosis. Next slide. Finally, we think this has results give an initial outlook into mental health, that these children and adolescents who receive any follow-up care are most likely to have either a substance abuse or trauma-related disorder, more so than motor vehicle crashes. We need to do further research to look at potential early screening and intervention to mitigate and improve this therapy, as is often done with motor vehicle crashes. And finally, research should examine the extent of undetected need for mental health care among those at risk for firearm injuries, because we do think that these data sort of underestimate the needs. Thank you very much.
Thank you, Dr. Eric. And last but not least, Jennifer Peruk.
Hi there, my name is Jen Peruk. I'm an MSU PhD candidate who is part of the ERPO Multi-State Research Collaborative. Today I'm going to be talking about our collaborative strategies for preventing and coping with vicarious trauma. Next. So violence prevention research can be really emotionally demanding. For example, researchers have described having disturbing dreams or reliving the traumatic events of participants. So although strategies for researchers preventing and dealing with vicarious trauma is increasing, there's little out there for firearm-specific researchers. Today, I'm going to present an emotional support model used by our collaborative while coding extreme risk protection orders, or ERPOs. ERPOs are civil orders that prohibit someone who's at risk of harming themselves or someone else from possessing a firearm. And so these ERPO cases can include really detailed and graphic descriptions of firearm violence, including suicide attempts, domestic violence, and mass shooting threats. Next. So our collaborative needed a model that could support over 50 coders working all across the country and who had varying levels of previous experience. So the model starts right at the beginning of the study. So during training, all coders watch a video of the PI talking about how this research can be difficult and describing all of the supports that we have. The training also includes links to other vicarious trauma literature. And importantly, this training is available for coders to access at any time in the project. So if coders want to revisit, they can. Additionally, coders meet every week to talk about coding issues, including cases that are bothering them. The PI also arranged for a mental health professional who is working on a different part of the study and who's actually an author on this presentation to be available if coders wanted to talk to someone one-on-one, not in a big group setting, and who isn't their PI. Daily, some coders start Teams videos and leave their cameras on while coding so they can talk about disturbing cases as they come up instead of holding it in and waiting for the weekly meeting. Additionally, PIs and managers encourage coders to break up their work time, a couple hours in the morning, a couple hours in the evening, and try to assign non-coding tasks to break up that coding. And finally, the study has a no questions asked policy in which coders can very easily switch out a case for a different case. Next. The summary here is that firearm violence research can be really difficult. And as this field grows and new students and staff are helping to conduct this research, it's important that researchers aren't just aware of vicarious trauma and know that many of their students and staff have their own personal experiences with violence, but actually integrate trauma considerations into their budgets, trainings, protocols, and supports. And our collaborative strategies can hopefully be used in other firearm violence studies to teach students and research assistants about conducting with and coping with emotionally demanding research. Thank you.
Thank you very much, Jennifer. So thank you all for your participation. I think we can have our presenters turn on their video. I would just say that it's really incredibly difficult to present all this rich information just in 3 minutes. So you all did a commendable job, really, trying to present it. We only have a few minutes left before I let you all go. A couple of questions I wanted to ask the team. Maybe I'll start with our first presenter, Sarah. Sarah, if I understood correctly, there seem to be some higher rates in 14 to 17 age range group, and then the much younger kids in terms of unintentional shooting rates. Do you have any hypothesis about what may explain that picture?
So, I mean, we didn't look a lot into that, but we did look a little bit at like what were the circumstances of the 5 and under ones. And I think what comes through pretty clearly is that 5 and under kids, you know, the level of their brain development. They don't understand the consequences of what they're doing. They also, many of them live in gun culture areas where they have toy guns in their home. They don't really understand the difference between a toy gun and a real gun and what the consequences could be. And so that's like one of the things that we saw. Most of the incidents with children of 5 and under were injuring or worse themselves or a little friend over for a play date, right? So so that's kind of what we saw. That's kind of what we saw in the much younger children. Whereas kids, when they get a little bit older, they start to sort of make a, you know, relationship between actions and consequences, and to be able to have, you know, heard enough about the danger of a gun to understand the difference between a toy gun. So, but we didn't do a deep dive on this.
Great, thank you. Might be something for future to think about.
Definitely,
Thank you.
thank you.
I appreciate it. Dr. Mason, one thing I wanted to ask you is, you also, just similarly in terms of the descriptive epidemiology and some of the patterns, it looked like the older age group, the mean age was a little bit higher toward the later cohort. Do you have any further elaboration on that? That was interesting to see.
Yeah, I mean, there's been a lot of talk about that in our group because we don't have definitive answers and we want to look into it. But one idea is that 4 years ago, these people of this age would have been at the peak rate for firearm homicide death in Chicago. So maybe this age group is just 4 years older and continuing their higher risk of exposure. It's difficult to know. I think we need a lot more information about where these people are in their lives at the time they die and the circumstances surrounding these deaths. Another idea that there might be a generational influence, that perhaps some of this group experienced the loss of a parent or loss in a neighborhood of people in their lives, and that might be influencing their victimhood, if you will. So I think we have a lot of work to do to figure that out.
Great, thank you. Dr. Bonney, one question for you is, so yes, the incredible importance of capturing these late death cases, it's something that we should really have in mind. Do you have any ideas, potentially ways of in the future to include these late death in the public accessible databases or make them more usable for research purposes?
Yeah, that's a really great question. I mean, I also, like many people today, have advocated for some sort of registry for non-fatal firearm injury, which theoretically would follow these patients out for some period of time. And also, there's a huge interest in the trauma surgical community right now for all trauma patients, including, you know, car accidents and things like that, about looking at long-term patient-reported outcomes and long-term outcome measures. So I think that we would get some sense of that if we invest in this sort of, you know, functional. There's a lot of interest in, like, you know, functional ability following trauma. And so if we invest in those sort of data systems, we would be able to do that. Australia actually does it remarkably well. Of course, they don't have much firearm injury, but they are able to follow those patients out like a decade after their injuries.
Excellent, thank you. So I'm aware of time, and I'm sure there are so many other questions that probably the audience members may have, and I encourage you to get in touch directly with our wonderful presenters and ask them. I probably have just 1 minute left to share with you that for your next session, you can choose from 2 of our mini symposium sessions. One is consequences of firearm violence, mental health risks for future violence and healthcare burden, or the examination of firearm policies and their effects on firearm injuries. If you need your links to the next session and don't have your email with links handy, head to childfirearmsafety.org and click on the link to live stream the FACT Symposium, and that will take you to the page with links for the next session. Thank you all very much for our wonderful presenters that did a commendable job in this really difficult and challenging task. And thank you all for the participation and listening to these abstracts. I hope you'll have a wonderful rest of your day.